and that was the N95 mask. We looked at face shields, we looked at so many things, and finally, over a period by the end of May, we started having a free flow supply of quality PPE with some standardization setting it up, and we continue to use till day. And I think now a time has come where the intensive care society, we need to relook at it, the type of PPEs we are wearing. They are required, but primarily to protect air contact and air attitude was there. But with the onset of use of new devices, we started feeling better, we started comfortable. I remember when we wrote the first time the Indian Society of Critical Care Medicine guidelines in our own ICU, people were very skeptical and it told me, some of them very bluntly and some at the back, Dr. Chaudhry, you are too ambitious. You should not go for non-invasive or HFNC. And I'm happy and glad that what we thought, what we looked at it, sometimes common sense and what you call is a conventional wisdom is far more important. And sometimes we get too much drowned at the level of evidence. And what is important is evidence does not mean the finality of a thing. So that's why you see now the standard has become the high flow nasal cannula. When we started using high flow nasal cannula, we realized they are guzzlers of oxygen. And then we started realizing also that the manifold which we are having, though having an adequate supply, cannot give us the sustain that pressures, because we are using more than 15 machines at any point of time, 10 to 15 when the peak came. And then we realized the challenges with the pipeline. And that is where when Dr. Dhruv Chaudhry says that Dhiren said, probably doctors need to know the design of their intensive care units. And for that, you need to be receptive. It's not anybody else's job. It's your own baby. You need to look at it. And I hope you will agree with me. Top can take up to 40 liters of oxygen. Therefore, it is not that you may not to simply look at high flow systems alone, but these systems can also deliver you oxygenation. So that was one thing when we saw in our services. Supply chain management in terms of getting diagnostics, sending samples in and out had become a challenge. Maintaining staff had become a challenge. Then how to keep that staff which is working into your intensive care. People were scared, they were not willing to go to home, they were all in quarantine policies, shifts, everything required reworking from each and every angle. And what I realized at that point of time was people were scared, not only in ICUs, but also in operating theaters, how to intubate them. So video laryngoscopes we started looking for. And our team innovated in a sense the boxes which were there. Today, probably people have become more confident and they may not be using it. But trust me, that was the time. I'm certain all of you and all of your colleagues must have been doing it. Additionally, then how to auscultate these people. Some of our students went a step ahead and they innovated. And always the necessity is the mother of invention. And today we realize what is the need and requirement of digital stethoscopes, which is needed and required if you want how to tackle it up. We started using technology, and today I've been happy to share with you. We are running at Italy ICU, and I'm grateful to Dr. Sandeep Devan, who's a Fortis group, who offered us as a part of CSR, and it has made a huge difference in terms of outcomes of it. And I think that the coming era is for telehealth, tele ICUs, and innovations. Then we were asked to look at the ventilators which are coming up, and especially the Aqua and all. We realized that the Bell ventilators which were come up, people in under the PMJ schemes, and also the Meditech, the beauty of them was that all of them had high flow systems, and we were able to use, and it was able to tide over the thing. Infection control was there, and after initial few days, we started seeing higher incidence of infection. We realized that people wearing the gloves were not doing the hand washing. So it has to be so in a sense, to get the behavior change among your colleagues, among your students, among your peers was the biggest challenge. If you really ask me, one thing which I really faced. And then another problem was coming up because in the government sector we have a huge deficit of nurses, and there how to take care of. We were treating patients, we were not able to give them the care, how to look after the care. Now, for that care component, bathrooms, ushering them and helping them eating their food to a breathless patient was becoming a nightmare. The quality type of food was being complained all the time. How to look after, how to do their daily utility things. We started putting if you ask me, the chairs, and along with it, we started now. Dr. Prashant McClure is sitting with me. They innovated, and he has been my 2IC throughout the system. Uh, we started using the plastic bags and putting it up so that it can be disposed of. So these are the few things which happened, and then we had no drug, no clue what is going to do. And then obviously over a period of time, the protocol started coming up, management protocol started setting up. So we started initially with lopinavir, and then gradually people were using hydroxychloroquine, etc. And now things have changed. And the one thing which made the change in the intensive care settings management has been the recovery trial, where the corticoids have been there. We have all been using 6 milligram to 8 milligram dexamethasone, but I think that's not a good idea for those. People may say it was your opinion, but time has come to do trials in these patients, because jack in the box approach cannot work. So we need to redefine depending upon body weight, severity of inflammation, other things. Because when recovery started, they had no clue what they are dealing with. Today we know for. And then we have additional thing have been seeing. We participated in research trials in the intensive care, and tocilizumab was supposed to be one which is going to be causing panacea and going to help us up. Tocilizumab, we did a trial. We have now sent it for publication. It was a multi-center trial, and we have enough experience, and the results will be coming up. Probably they may not be no different, but patient selection is important. And what we have realized is that if somebody has an hyperacute syndromes, then you may use it. Then a lot of hoopla happened about plasma. Plasma, we were under press. The government asked me, and we established 5 plasma banks in the state. But the press, and we just missed participating in Placid trial. But what we have seen, it is not effective once actually you develop antibodies and later part of it. Now people are not tom-tomming about using in 5th or 6th or 7th or 8th day. The question is to whom to use, A. And B, we need to know what is the neutralizing dose in neutralizing titers which are required. Nobody has an answer. But nevertheless, a shift has taken place from late to early use of plasma as a part of passive immunization or as a part of natural polyclonal antibodies which are coming up to use it against what you are seeing today as a Regeneron. Who is giving us an answer. And I think we need to use antivirals. Yes, it is not a very effective antiviral, but at the same, this is the best we have. So I have no confusion in my mind that yes, we need to do it. The government of India did a emergency use authorization, and practically everybody is being used, and we are using also early patients having 2 or more comorbidities. And what we learned from our experience in Haryana of more than nearly 2,800 deaths in my institution, 401 deaths, is that majority of the people who are getting severity were not morbidly obese, but they were the people which we call healthy, which were having overweight. And when with this overweight was combined with diabetes, it was combined with other things, we started sort of those problems. So for me, anybody who has got BMI more than 24, 25 is a risk factor. And along with you has a diabetes, like insulin resistance, or there is a single first onset hyperglycemia, which we try to differentiate through HbA1c. If it is there, is a challenge, and we see it very closely. And this is a group of patients who are actually getting multiple problems. We have, it has also given us a chance to consider and think in terms of ACMO services. We have not done it, but in my institution yesterday, for the first time, we have started now using ACMO services also. So people have also realized that men behind the machine are very important, but equally important to have a good quality machine. What we have also realized is that we need to have an indigenous R&D so that we can customize and use the things as and when what is required. And finally, in the communication thing, which is important, one bed, whom to give. Here, the medical ethics have been challenging us day in and day out. Is it to be restriction to the elderly, giving it to the young people? Sometimes it becomes very difficult, very challenging. And trust me, all of you have worked in intensive care settings. Going into an ICU, 20 people lying there, somebody in oxygen, somebody is not able to clean themselves, too breathless to eat. It's a scary sight. And what we are realizing over a period of time, communication, mental health issues have started coming up. People have been complaining constantly. We are not talking to them as what is required. Doctors, nurses needing counseling 24 by 7 basis. I think that's a huge, huge challenge. And for the first time, I have been saying that this is the time, it is a golden time for us to ensure, usher in changes because it is a disruptive things which have, COVID has been a disruption and disruption lead to resurrection. And I think it's a challenge for us all in the medical fraternity, as a society, as a social that we need to move ahead. And I'm happy to share with it that our department, our institution, and myself participating in a number of these trials, which includes PCG, but right now we are in the third phase of Covaxin. So this is a whole gamut which is there. But trust me, from organization to manpower management to showing utters to showing leadership, courage, resilience, and able to sustain yourself and pass through this ambush has been a biggest challenge. And I'm happy that my team has come up to that level. And intensivists in general and our society has provided support to them. And few of them have become the shining arm. Thank you very much for patient hearing. And I'm extremely sorry. I have no slides. I just spoke from my heart. Thank you very much.